All right, it's 8 o'clock. Good morning. Thank you for joining us at the Department of Medicine's Grand Rounds. On behalf of Dr. Frazier, Costco, Spencer, and myself, we're so glad you're here. We can't wait to continue our Grand Round series highlighting our incredible senior residents. Starting off, we're excited to hear from Dr. Kevin Shim. Dr. Shim grew up in Phoenix, Arizona, where he attended the University of Arizona for his undergraduate studies. He then went to receive his MD and PhD at the Mayo Clinic in Rochester, Minnesota, where his work focused on viral-based immunotherapies for cancer before continuing his training here with us. Dr. Shim is interested in pursuing a fellowship in Heme-Onc in the near future. Amongst his hobbies, he enjoys camping, hiking, and board games. Following Dr. Shim, we are delighted to have Dr. Kai Jones. Dr. Jones is from Tulsa, Oklahoma, and studied biology and anthropology at Washington University. She then stayed for medical school, internship, and residency, bit of a lifer. She's interested in endocrinology and is in the Mentors in Medicine program. She's also in the Residence Fellows Diversity Initiative, a program at WashU BJH Children's Consortium, which is working to increase recruitment and retention of underrepresented minorities at WashU, which is the focus of her talk today. As a reminder, this and all previous talks are available at the Department of Medicine website and uploaded to the new Department of Medicine YouTube channel, so please check it out. Today, we're going to hear from both speakers, have questions at the very end, so please feel free to send any questions along to me as we go. With that, Dr. Shim, you can go ahead and share your slides and we'll get started.
Good morning, John. Thank you. Let's see, do this here. All right. Good morning, everyone. Thank you, John, for the introduction, and thank you, everyone, for tuning in to Grand Rounds today. I am very grateful to have been given the opportunity by the program to talk about a subject that I'm very passionate about, which is data, how there's oodles and oodles of it, and what on earth we're going to do with all of that data, particularly as it applies to healthcare. I am a resident and have no financial disclosures. So I think at the end of the day, the core of our job as clinicians comes down to gathering data about our patients, whether it's their symptoms, their lab data, their imaging, and synthesizing it into something that is information that's understandable by our patients, helps to advance their care, and helps to advance the field of medicine. Anyone who's been in an Epic chart recently, or really on the internet at all, knows that the data that we're working with today is very different, and it continues to grow and it continues to change. As an example, here's a figure from a paper that was published last year, which shows 25,000 patients and data collected from their free text medical records and has clumped them into different types of heart failure, with each different color on this graph representing a different type of heart failure. One of the claims that was made by the authors of this paper using this unsupervised clustering of heart failure is that those patients with decompensated heart failure, over here in the blue, end up having a greater than statistically significantly normal amount of lymphadenopathy noted in their imaging findings and in their chief complaints. And it's our job as clinicians to be able to interpret these types of findings in the future and to know really what we can do with this information to evaluate them and help our patients. So today, what I'd like to talk about is big data, to give us a working definition of what precisely that is and what challenges come from working with it, and talk about some techniques that are currently being utilized in clinical medicine, as well as by our colleagues over on the biomedical side of things, to help us interpret and visualize these data so that we can make some sense out of them. And those two techniques are clustering and dimensionality reduction. So if you Google big data or just go looking around on the internet, you're likely to find a bunch of deeply unhelpful pictures, like this series of tubes made of numbers and this cyber AI lady, all in these shades of navy blue and cyber blue. But I hope that a federally commissioned definition from a working group based on big data will be more useful than these things. It is paraphrased as vast and varied data from an ever-growing number of sources that requires advanced techniques and technologies to enable the capture, management, and analysis of the information. And what I like about this particular definition is not only does it point out that there is a whole boatload of data, but also that the way that we need to approach the data, the way that we need to think about the data to even glean meaning from it will require something new and is going to require us to put our heads together to do something different. Another popular way that big data is defined is with the 3 V's, and the 3 V's are volume, variety, and velocity. Volume, it's pretty easy to imagine for anyone, again, who's looked through a patient's ICU chart. You can see WashU here on this map of the Accrual Clinical Trials Network, which is currently a centralized database that's being put together with all of these academic medical centers, putting together the millions of patients that are treated at WashU with the millions and millions of patients that are treated around the country. As you can see how this volume of data is something that's staggering and will require special techniques to analyze. When I said clinical data just a minute ago, you probably had in your mind something that you associate with clinical data. Maybe it was the note that you wrote last night or the labs that the firm teams are looking at as we speak on their patients. But I think it's important to remember how many different kinds of data come out of healthcare and what a wide variety of data formats they come in. So everything from the green man that tells us how many lines and drains we have in a patient to all of the pixels that are contained in a CT scan, all represent vast sources of data that pose special challenges because of the different variety that they pose. And then finally, Twitter makes a lot of data, but I think that our ICUs in healthcare can really give them a run for their money. This is, for example, 3 hours worth of vitals out of the ICU and is probably enough to keep a data scientist busy for quite a while. I think that together, these 3 V's that define big data in all of the different domains that it exists in are particularly relevant to healthcare and help to highlight some of the challenge that healthcare is facing currently and will continue to face in the future. As another example to sort of put the scope of this in a framework that's more understandable and also to highlight what a challenge it's going to represent for us. I have a little example here. This is a picture of a dog. It is 3.6 megabytes on my computer, which is that number of bytes there. I did some back of the napkin math for my own healthcare chart, which includes about 8 notes, 5 sets of labs, and a CT abdomen pelvis. And that's 260 megabytes, most of which is the CT abdomen pelvis. And there's also a published number from someone else who's done some back of the napkin math about Kaiser's total healthcare data, including imaging, that was collected in 2011, so 10 years ago, which comes out to 30 petabytes, which is that number of zeros. To make sense of that number of zeros, I have a little conversion for you. If we took the Doge picture and changed it to milliseconds, it would come out to about 1 hour, that number of bytes. And my healthcare chart, if converted to milliseconds, would come out to about 3 days. This PowerPoint is about 1 day in data size. And if I converted Kaiser's data in 2011 into milliseconds, it would come out to 100,000 years, which we think is about when woolly mammoths were roaming the earth. Now, nobody really knows how much healthcare data exists at any given moment and at this moment in time, but most estimates right now are centering around several yottabytes worth of data, which is very fun to say, and is also 1 billion times the amount of data that was contained that Kaiser had in 2011. And this is several, if I converted this to milliseconds, it's several times the length of our universe and really begins to become not meaningful in that regard. So suffice it to say, it's a whole boatload of data and it's continuing to come at us and it's coming at us pretty dang fast. So the question then becomes is, as clinicians, what are we going to do with these data and how are we going to analyze them? And I've had the privilege of working with my mentor, Dr. Stephen O, in his lab using multiplex imaging technologies to use some techniques that are already beginning to come to clinical medicine. And I believe will continue to provide utility for us as we move forward with this massive amount of data and our ability to process it. This is a bone marrow from a human that has been processed and stained with, in this particular image, a nuclear stain where each blue speck is the nucleus of a cell. And we currently possess the microscopic imaging technology to individually pick out any one of these given cells and stain it for 50, 60 markers at a given time. I can stain for CD3, CD4, interferon gamma, whatever my immunologist heart desires. And I can do this simultaneously for all of the 2,000 or so slides that are present on this particular image. And as you can imagine, generating this 2,000 row long by 50 column wide spreadsheet represents an enormous challenge for data analysis and processing for us to glean any sort of relevant information from it. And what I would posit to you all this morning is that the challenge that we face in clinical medicine, that we face as clinicians, is more or less the same, which is how can we take our patient panel, our hospital inpatient population, et cetera, pinpoint an individual patient or individual and gather data from those individuals amongst all of these other individuals and find how to deliver the best care for them or what interventions may be required to help them to live their best life, more or less. And so I'm going to talk about two different techniques. The first one is clustering. As the name suggests, you basically are using a machine learning algorithm to lump data points and subjects, in this case, probably patients, together into groups that help you to glean insights about those groups. So the core principles for the clustering algorithms are first that this is a descriptive, not prescriptive technique. Much like any test that we order or any piece of data that we collect, these algorithms help us to learn about the structure of our data, but do not prescribe meaning. Ultimately, at the end of the day, that still remains our job in the assessment and plan. And the next thing I'll like to point out is that clustering is an unsupervised method, meaning it does not require substantial human input. Put another way, my grad school PI would say that if you put garbage into a clustering algorithm, it will cluster it for you and it will put out garbage clusters. And then finally, at the core of the clustering algorithms that I'll talk about today, and also the dimensionality reduction techniques I'll talk about in a moment, is the concept of Euclidean space, which I think is important to review at this time because it helps to give you an intuitive way to understand these methods. And so I've got the floor plan here of 16400 Barnes Jewish Hospital South Campus. You can see all the lovely patient rooms in a row here. If I put this on a familiar XY coordinate system and told you I had a green patient and a red patient, and I'd like you to calculate the distance in feet between them, it may take a little bit of head scratching at this hour of the morning with the amount of coffee we've had, but we would probably arrive at an equation that looks something like this. And I could tell you the number of feet between these two different patients. Well, if I asked you instead of just between these two patients, could I also ask you to do it for groups of patients? The answer is yes, I'm pretty sure. We could do this. You would be grumbling at me because you'll have to do iterative calculations between each point and every other point in this two-dimensional space, but more or less the same math. But then, hang on to your butts. If I asked you to calculate the distance in Euclidean space between FEV1 and FVC from these patients' PFTs that they've had in the last couple of years, I would argue that you could also do the same thing between each of these different patients by calculating their Euclidean distance from one another in FEV1, FVC space. And this is the basis of clustering. So the two types that I'll talk about that are commonly used are hierarchical clustering and k-means clustering. Hierarchical clustering, I'll show you here with this example of 6 dots, which I'll say are 6 different patients and their PFT values. What the clustering algorithm does first is it calculates the Euclidean distance between each point and every other point. I've shown it for this central point here, but imagine it happening for every point at the same time. And in one iteration of this clustering, it basically just groups which point is closest to that point and has the shortest distance amongst all points calculated into a group. And it does this process iteratively, again and again, calculating the distance and clustering cells together based on which ones are closest. And it continues to do this until all of the cells are contained within a single group. And there you have different clusters that can be split at different levels in a hierarchical manner. And that's hierarchical clustering. The next one I'll talk about is k-means clustering. The K is for the number of clusters, and it tells you right away there's a little bit more user input that's involved because ultimately, at the end of the day, whoever's running the algorithm has to decide how many clusters get used. And it starts out with the same data here, but in this algorithm, it creates 2 random points in this example, 2-dimensional space, and it calculates the distance between every data point and these 2 random centroids that it's created in your data. And it basically assigns the data points to whatever centroid it's closest to. So in this example, it happens that there's 4 green ones here and 2 red ones here. The algorithm then moves this centroid to the center of this polygon thing that it's created. And you guessed it, it repeats the process over and over again, moving the centroids over and over again until the centroids stop moving. And you can see in this example, we've got 2 nice clusters of green dots and red dots. And that is k-means clustering. The punchlines for these clustering algorithms are first that the algorithms themselves generate groups that in Euclidean space represent points that are more similar to one another than points that are in other groups. And to always remember when interpreting these data, whether moving forward with your own projects or analyzing published data, to remember that the clustering itself is a descriptive, not prescriptive method of data analysis. So here's an example of an ICU study of 68 ICUs that looked at 5 features of end-of-life care and used k-means clustering to break the different ICUs down into different groups. We got 3 clusters here that they found. And on the y-axis in this plot, you can see the fraction of ICUs that had this particular desirable ICU outcome at end of life, for example, extubation before death. And they also have absence of CPR, et cetera, et cetera. The upshot of this study was that they found 3 clusters using this unbiased mechanism. They just punched in the data and these clusters came out and they prescribed this meaning to it. And they found that cluster 1 does a poorer than usual job of extubating patients before death. Cluster 2 does a poorer than usual job of having patients be delirium free. And cluster 3 is a bunch of tryhards that does very well at all of the measures that they looked at. And I think that what's very important and exciting about this study is not so much that they found 3 different clusters, but rather that when they go back and look at the features of these clusters to find what's driving these differences, they find nothing that you would expect. Rural versus academic, large versus small hospital, the MICU-ness versus SICU-ness of the ICU, et cetera. None of those things were statistically significant. And I found the meaning that they prescribed to these data very insightful, which is that there is unacceptable variation in ICU care between these different clusters. And it's something that we need to look into in terms of different measures than what we usually measure to see what we can change and improve. The next thing that I'm going to talk about is dimensionality reduction, which in a nutshell is taking data with a lot of columns and smooshing it down into lower dimensions so that we can visualize it. So once again, I've got my red patient and my green patient. And if I actually want to calculate the distance between the red patient and the purple patient from 14.4 to 16.4, we'll use more or less the same math with an additional Z parameter to get to this particular distance. What if then I add on a 4th dimension of age, for example, and I want to calculate the distance in the age dimension? The 4th dimension is already one more dimension than I can visualize for you. And if I add on weight as the 5th dimension, that's already more than I can comprehend with my squishy human brain. Fortunately, if we keep adding on these dimensions, the math remains actually the same. And I can go up to 15 dimensions, 20 dimensions if I like. Cold, hard steel of the computer doesn't really seem to mind. And what I'll point out here is that really the distance in Euclidean space between all of these different points ends up being the same formula and is really based on the same principles. And so it's on that note that we can talk about the core features of dimensionality reduction, which are to take information that has multiple dimensions, high dimensional data, that is to say, data with a bunch of columns in your spreadsheet, and moosh it down into lower dimensions so that we can visualize it. And the 2 types I'm going to talk about briefly are principal components analysis, or PCA, and t-SNE. So PCA, here's an example with 9 different patients, for example, with CHADS2 on the x-axis and age on the y-axis. And what the PCA algorithm does in a nutshell is it finds a line that is as close as possible to all of these data points. And if you're able to, at this hour of the morning with the amount of coffee you've had, imagine also that this line is in multidimensional space as close as possible to all of the patients in all of the dimensions that you're measuring. The algorithm then projects the data points onto this line and in effect creates a situation where you've taken a lot of dimensions and mooshed them down into a single dimension. And this single dimension, as it turns out, captures most of the variability of your data set. And it does so by capturing things that co-vary. So in our data set, for example, let's say we're looking at CHADS2 and age, we may find that those things correlate positively. And as age goes up, so does CHADS2. And we can call this principal component that has been created, for example, perhaps CHAD age, and nickname it that. Basically, the key points from this are that this algorithm creates principal components that are lower dimensional representations of your data, and it generates loadings, which are the fraction of the data that's represented by each individual variable. t-SNE will blow through quickly, which is basically another algorithm which takes these 9 data points, calculates the Euclidean distance between each of the points, and generates something that's called a similarity matrix, which is well above my pay grade in the scope of this talk. But basically, using the distance between points creates a heat map of sorts, showing you that these red dots are really close to each other and further apart from the yellow dots and the blue dots, et cetera. What it then does is it uses the similarity matrix and it saves it, and it takes all the data points and splats them randomly into a lower dimension. So it literally just shakes up all the data points and it takes it from 2 dimensions on the last slide to 1 dimension here. Now the similarity matrix, when you calculate the distances between each of the points on this single dimensional line, is all mixed up. And it uses a magical algorithm under the hood to slowly move each of the points such that the matrix gets as close as possible to what it was at the beginning. So the punchline for these techniques is, first, that they're methods that don't actually modify the data. They simply give a little bit in the sense that they lose some of the higher dimensional data in one manner or another to help us visualize it in lower dimensions. PCA is very useful because it can tell you what fraction of the variability of your data is accounted for in any given parameter. And t-SNE I like to think of as the Monet of my data. It provides a sort of gestalt of what the higher dimensional data may contain. So quick examples here. First one is this JAMA study, which looked at about 3,000 patients and 11 CT scan parameters and calculated principal components from it. And what you can see is the 11 CT scan parameters on the y-axis of this graph and the fraction or the weight of the variance that's explained by each one of them. This principal component they call global calcification, basically because they see a bunch of calcium in the arteries and on the valves of these patients. And they also calculate other principal components. This one they're calling adiposity for intrathoracic fat, et cetera, et cetera. And when they graph these 2 principal components on an X and a Y axis, this is obviously a schematic, they find that they sort of clump into 2 different groups. And one of the groups, as it turns out, the blue group in this picture does well. They die less soon than the second cluster. And they also have less CVD. I think what's really insightful and incredible about the study is that they've taken data that's contained within the pixels of CT scans that already exist and lumped them into clinically relevant populations. And I think what's exciting to think about is what we can do with this type of information in the future with all the CT scan data that's laying out there. And then finally, this brings us back to the figure that was presented at the very beginning of this talk, which is a study out of Russia at a single medical center that looked at 25,000 symptoms, mined through their notes for symptoms and chief complaints, and used k-means clustering to find different groups. And they used different Ks to find different iterations of what the best number of Ks would be. You can see, for example, all the heart failure patients are on the left here. And the first major branch point, to no one's surprise, is ischemic heart disease and non-ischemic heart disease. To any of you that tuned into Preet's talk last week, I think you'll be excited to see that here is female heart failure as a major branch point in this set of clustering that was arrived at by this algorithm. And when you follow these down to the total 15 clusters that they finally arrived at, you can see that, as she mentioned, with microvascular cardiac disease, we have hypertensive heart disease and cerebrovascular disease. And I think that what's very interesting is how high up this branch point is in the data that they found. They then take this data, this several hundred columns long, 25,000 row long data sheet, and smooshed it down using t-SNE into 2 dimensions so that we can visualize it, and colored each of their k-means clusters a different color. And so we return to the question that they brought up at the beginning of this paper, which was, what do these clusters mean? Do I need to use machine learning to tell you that NICU patients are different than those with aortic valve disease? Obviously not. But I think that finding major branch points in cardiovascular disease, like female heart disease, as shown on the last slide, or their assertion that lymphadenopathy and decompensated heart failure is something that warrants further investigation, I think are incredible insights that these types of techniques are going to help us to see in the future and are going to help drive clinical innovation forward. So in conclusion, what I'd like to say is basically that the future is now. Healthcare data is here, obviously. We look at it every day. And what I'd like to point out is that these data are big data, and that it's our job really to steward these data and to ultimately prescribe meaning to that. And the meaning that we prescribe to these data is going to require us to understand and know how these data are processed. So the last thing I'll leave you with is a courtesy of Dr. Peter McDonald, former clinic chief, who has been toiling away at generating data for each resident and their patient panel. So for example, my panel is somewhere down here with the number of patients, average age, gender, etc. And what I'd like to point out is that this spreadsheet is a type of big data. This is high dimensional data that we are going to be confronted with very regularly in the future. And it'll be our responsibility to look at these data and use them to our patients' benefit and to advance medicine in the future. That's all I've got. I'd like to thank everyone, especially my mentor, Dr. Stephen O, and the unending patience from Dr. Amelia Van Handel. Thank you all.
Thank you so much, Dr. Shim. That was fantastic. As Dr. Jones sort of gets her slides up and started, I'll just make a reminder that if anyone has questions, which I'm sure we all do after a very complicated talk, please feel free to put them in the Q&A or the chat, and I will try to address them towards the end. Let's make sure that Dr. Jones has the ability to get her slides up. Perfect. There you are. All right, perfect. Take it away.
Okay. Thank you to Dr. Hickman and to Dr. Shim. Thanks to Hickman for the wonderful introduction. So today my presentation will be on the recruitment of underrepresented minorities in medicine. I have no disclosures. So by the end of this talk, I'd like for you to understand the current demographics of the US physician population and also understand the impact of increasing physician diversity on health disparities. We will review some best practices in the recruitment of underrepresented minorities in medicine and some drawbacks associated with these best practices. Then we'll shift gears to look a little bit closely at our own institution and some areas for possible improvement in our recruitment. Just as an introduction, the current physician workforce does not represent the racial and ethnic diversity of the population that it serves. A key term that I'll use throughout this talk is underrepresented minority in medicine, or URM. And this is defined as the racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. Currently, this includes Black, Hispanic, Latinx, American Indians, Alaska Natives, Native Hawaiians, Pacific Islanders, and mainland Puerto Ricans. So this graph is representing the percentage of underrepresented minorities among medical school matriculants in the United States from 1950 to the year 2000. So as you can see, in the late 60s, when more students of color were allowed to apply to medical school, we saw a quick increase in the number of underrepresented minority medical school matriculants. However, this continues to increase, but not on track with general population growth. This is specifically looking at Black and African Americans in academic medicine, where we can see that we represent 13.4% of the population and only 8.4% of applicants to medical school. We represent 5.1% of residents and about 5% MDs. Switching to look specifically at academic physicians, we represent about 3.6%, but reaching the highest percentages of professors in medicine, we represent 1.9%. So as you can see, these numbers tend to drop off when we get to people with higher ranks. So this idea of physician parity, or having a physician population that looks more similar to the US population, was examined specifically looking at resident physicians in an article in the Journal of General Internal Medicine just this year. And they looked at the 13 most popular medical specialties and did a cross-sectional retrospective analysis comparing the populations of these residencies to the US Census data. And only the field of radiology had a statistically significant increase in their proportion of Black trainees. And even with this statistically significant increase, it would take 77 years for 13.4% of radiologist residents to be Black. So as you can see, that is a long time. Specifically looking at Hispanic or Latinx trainees, obstetrics and gynecology, emergency medicine, internal medicine and pediatrics, and orthopedic surgery demonstrated statistically significant increases in their proportion of trainees. However, it would still take 35, 54, 61, and 93 years respectively to reach representation comparable to that of the United States population. So although we've made improvements, these improvements are not enough for us to reach physician parity. So given these numbers, improvements in physician diversity have become a core strategic priority of the AAMC. So they advocate for extensive research on physician workforce diversity and anti-racist policies. They also advocate for more holistic review processes to increase the number of URM physicians. We'll talk a little bit more about this later. They also advocate for increased involvement in pipeline programs in science, technology, engineering, and mathematics. One such program through the AAMC is called SPEP, and it's the Summer Health Professions Education Program. It's housed at over 20 institutions across the country and is geared towards college students from underrepresented backgrounds to encourage them to pursue careers in health sciences. Oh, sorry there. So just looking at the impacts of a diverse physician population. So increasing physician workforce diversity may work to eliminate health disparities. We know that physician supply is inversely related to the concentration of Black and Hispanic residents in an area, and that non-white providers provide a disproportionate share of the care to Medicaid populations and the medically underserved. Race concordance has also been associated with increased seeking of preventative care, increased rates of cancer screening, and medication adherence. Therefore, increasing the number of physicians from underrepresented backgrounds can help to address issues of health disparity by working to improve access to care for those from underrepresented backgrounds, and also increase rates of these preventative measures that can help with life expectancy. So taking all these things in mind, knowing that there's multiple factors that contribute to the diversity of a physician population, how can one institution work to increase their number of underrepresented minorities? So we'll look at 3 different cases of institutions who have done this using different approaches. So the first is the internal medicine residency at McGovern Medical School. So this is a residency program that's housed at an institution where greater than 50% of their patients identify as Hispanic or Latinx. And given that 5 of the 40 interns identified as underrepresented minorities, the institution instituted 2 categories of interventions. The first category were interview day specific interventions, where they worked to highlight the diversity of the region of Houston, Texas, and made an explicit statement of the institution's commitment to diversity. They also worked to have increased faculty presence from underrepresented backgrounds. Secondly, they enacted the holistic review process, where they worked to eliminate step 1 minimums and require implicit bias trainees for interviewers. They also had a more standardized set of interview questions to help eliminate bias as a part of the interview process. So looking more closely at their holistic review process, they took all applicants, and if they unfortunately failed one of the USMLE exams, they were not offered interviews. However, if they passed step 1 or step 2 within 10 points or lower than the established cutoff, they screened their application for red flags. And if no red flags were present, they then gave each applicant an experience or attribute score. Components of this score included their commitment to the underserved, substantial leadership roles, Spanish language fluency, and whether or not the individual represented the diverse population of Houston, Texas. If those individuals got greater than 4 points, they were selected for an interview. So looking at their outcomes, so they ultimately increased their number of URMs matriculating and interviewing at their program. Specifically looking at the holistic review process, they took 138 applicants that would have been not considered based on their STEP score, and 35% were interviewed. And ultimately, they increased their percentage of URMs matriculating from 5 out of 40 to 13 out of 41. So this program highlights the importance of using a holistic review process to increase the number of underrepresented minorities that you're able to interview at your program. Furthermore, it highlights the importance of explicit statements of diversity and also increased faculty presence during recruitment events. We'll look a little bit more closely at a different residency program in emergency medicine. So in the year 2008, the program directors for emergency medicine got together and established 11 recommendations to help increase the diversity of their programs. Some of these things I'll highlight are very simple, where they ask programs to verbally recognize the diversity presence in their residency program, express the desire to recruit residents from diverse backgrounds, having a more holistic review process, developing curricula that address topics of diversity, cultural competency, and bias, and also increase the involvement of faculty and have more recruitment events and dinners specifically for underrepresented minorities. So those recommendations were enacted in 2008, and 10 years later, less than half of the programs had done 2 or more of those things. And like I said, some of these things were fairly simple. So as Denver Health residency had not done 2 or more of those things, they enacted 3 strategies that they decided to take in order to increase their proportion of trainees. So the first thing was a funded visiting elective. So they allowed students to rotate in their emergency department and gave them the opportunity to learn more about the program in a month-long experience. Also a funded second look program, where they asked students who had already interviewed to come back at their institution and take a closer look at what things they had to offer. Also, they increased their involvement of URM faculty as a part of the interview day. Looking at their outcomes, they increased their number of underrepresented minorities that interviewed at the program from 7.1% to 14.8%. And that was an absolute increase of 20 to 58. They also increased their number of, or percentage of residents from 5.9%, as you can see, that was just 1%, to 4 out of 17, or 23.5%. So this Denver Health program really highlights the importance of having visiting electives, so opportunities for residents from underrepresented backgrounds to showcase their talents and get to know faculty at the institution. Finally, we'll take a quick look at the University of Chicago. This was actually a publication that was just released in the New England Journal, where authors there stated that 11 out of their 22 program directors no longer use USMLE Step 1 cutoffs for interview selection and ranking. And they've been doing the holistic review process for quite some time. They also noted that 84% of URM applicants to their internal medicine program interviewed with at least 1 faculty member from an underrepresented group, and 11% interviewed with 2 such faculty members. So they were able to have applicants interview with ethnically concordant faculty members. Additionally, they were able to have a very strong increase in their number of underrepresented minority residents, being that their intern class this year was 25% URM. So some identified common practices through these studies and others, first being the explicit statement of an institution's commitment to diversity. So this is important because it shows applicants that these institutions at least recognize that it's important to have folks from diverse backgrounds. Additionally, highlighting the diversity of the region shows applicants that they will be able to take care of populations that look like them. Furthermore, these holistic review processes are ways to highlight factors that make applicants qualified to be a part of their program. Additionally, it helps reduce the effect of economic inequalities that are associated with preparation for these exams, as some of these applicants may not have the resources to get additional assistance with these tests to get higher scores. Also, increasing the involvement of URM faculty during recruitment and selection events is a strong endorsement of the program. It demonstrates these underrepresented applicants that there are people that look like them at the institution that are thriving. Furthermore, visiting electives also allow applicants to showcase their talents and an opportunity for the departments to get to know these individuals specifically. So some drawbacks associated with these approaches. So of course, most of the faculty that authored these studies were a part of interview selection committees, deans of diversity. So of course, this may introduce some bias into the data. Also, this idea of increasing URM faculty / resident presence during these recruitment events may worsen this idea of the minority tax. If you haven't heard of this before, this is defined as a tax of extra responsibilities placed on minority faculty in the name of efforts to achieve diversity. So we're asking folks who, based on the statistics, may not be at the highest ranks of professors to do additional work to achieve these diversity. And for example, at this Denver health emergency program, they only had 5 URM faculty members during this intervention. So essentially with this intervention, they're asking 5 more people to kind of give time out of their busy schedules to do this recruitment event. So it's important to note that we may be placing, undue burden on these individuals. It's also this idea of perceived fit. And I'd like to shout out Dr. Zarate in the Department of General Surgery, who sent out an online survey distributed to residency applicants just this year in the setting of COVID. And all the applicants self-assigned fit scores to the program they ranked first. So this is the program they most wanted to go to. And compared to white males, female applicants from underrepresented backgrounds and female applicants from other non-white race programs had lower fit scores with their top ranked program. So it's important to think about, how these institutions are portraying themselves and to see whether or not these people feel that they'll be in an environment where they'll be supported and where they can thrive. So we'll look a little bit more closely at our own institution. So just for context, so this is a graph of the number of URM residents at WashU from 2005 to 2015. So just to remind you, this includes Black, Latinx, Native Hawaiian, Indian American, Native Pacific Islander, and mainland Puerto Rican. And so starting in the year 2005, we had 32 applicants from those backgrounds. So across the campus, that's not a very large number. And because of this number, we increased our recruitment efforts through a couple of programs I'll talk about later. So in 2008, we peaked around 72, and kind of since then, we've been between 61 and 70 residents total. And as a reminder, we have a large campus of greater than 850 residents. So a couple of programs that we have here that you may have heard about. First is our visiting medical student elective. So this is a program established in the fall of 2007, and it's through the Office of Diversity Programs. Of note, it is a funded visiting elective for underrepresented minorities to come to our campus and rotate with our various services for about a month. And since its inception, 21% of visiting students join a residency program at WashU. So this is a program with a pretty great track record in recruiting underrepresented minorities. Additionally, we have the Washington University Minority Medical Association, which was established in 2006. It is an organization that is resident run, and its mission is to assist the recruitment of underrepresented minority residents and fellows, and also work on professional development for members. We also have RFDI, or the Resident and Fellows Diversity Initiative, which I am a part of, along with some other folks in the department. So it was established in 2006 as well, as a joint effort between Barnes-Jewish Hospital and the Office of Diversity Programs. And its goal was to enhance the recruitment and retention of underrepresented minorities and fellows, with the goal that eventually recruiting and retaining residents and fellows will lead to a more diverse physician population in general. So I think some areas for improvement. First, to start with our visiting elective program. So as I noted, this is a funded opportunity for students from underrepresented backgrounds to come to our campus and get to know faculty and see, all the wonderful things that we have to offer here, specifically related to their training. And because 21% of those people join the program, I think it represents an excellent opportunity for us to increase recruitment. I know the Office of Diversity Programs goes to local and national conferences for both the Student National Medical Association and the Latino Medical Association, which are organizations that are targeting underrepresented minorities and trying to help them in their journeys to become clinicians. So increasing our promotion of this program, I think will benefit us in the long term in terms of our recruitment. Also, increasing our recruitment from Washington University School of Medicine. So it's a well-known statistic that about 1/3 of all medical students that graduate from WashU choose to pursue their residencies at Barnes Hospital. And so as the numbers of underrepresented minority medical students from WashU increase, hopefully we'll be able to tap into that population and increase our numbers as well. Also identifying mechanisms to increase retention, like some of the efforts through RFDI, to increase our pipeline to faculty. So then we can work to address and kind of work to aim to have more involvement of our underrepresented minority faculty in our interviews. Also improving and supporting WUMA, or the Washington University Minority Medical Association. So like I said, this is a resident-run organization that's tasked with that responsibility to help with their recruitment. And given that residents are very busy in their training and there's a lot of kind of shuffling from year to year with leadership, I think having a stronger support of this organization will help with our recruitment as well. Also, if you're listening and you're a member of a national society for your specialty or a national society for general internal medicine, promotion of specially related societies for mentoring is a good approach to help mentor our underrepresented minority trainees. Specifically, I was involved in the FLAIR program, which is through the Endocrine Society, which stands for the Future Leaders Advancing Research in Endocrinology. So this is specifically a program geared towards underrepresented minorities who want to pursue careers in academic endocrinology. And I was able to go to a national conference and meet with endocrinologists that look like me. So that was a very helpful area, which I think is something that we should promote. So if you hear about those organizations as a part of organizations that you're a part of, making sure that our residents are aware of that as well. So just some conclusions, although we've made improvements in physician diversity over time, these improvements are not on track with general population growth, and residency programs and institutions must adapt approaches to addressing these issues. Some best practices that we've identified include increasing the number of visiting electives, increasing the presence of URM faculty as a part of interview days, having more explicit statements of diversity, and thinking about the holistic review processes. I think this is very interesting because as step one will transition to being a pass-fail board exam, how will this impact our recruitment and how will we kind of work with this? So just some acknowledgements. These are on the right are some pictures from different WUMA events we've had throughout the years. The one on the top right actually was when I was a first-year medical student at WashU. So you may recognize some of these individuals who've actually gone on to be faculty members here or work in our Department of Hospital Medicine. So this was a really excellent opportunity for me to meet and network with these people, before I was even a resident here. The other pictures are other pictures from other events that I've been a part of at my time here at WashU. So I really do appreciate these organizations giving me the opportunity to network with these individuals. So I'd like to thank Dr. Frazier, Dr. Costco, and the ABPs, Dr. Wren for helping with the edits for this PowerPoint, Dr. Will Ross, who's in the Department of Office of Diversity Programs in the Division of Nephrology, who's been very helpful for my both professional and personal development here at WashU, the chiefs and fellow House staffs. Thank you.
Dr. Jones, thank you so much for a fantastic talk and a very important talk at that. I don't see any questions currently in the Q&A section. I can pose a couple to you, and I'll probably start with Dr. Jones first, just since you're still up here.
Yeah.
You mentioned certainly that there's a paucity of physicians in Black and Hispanic areas in particular, and that there's better concordance in outcomes for folks better outcomes in health when there is racial concordance. Is there any evidence that underrepresented minorities are moving to these areas to practice and improve that, or do we just not have enough physicians yet to see any change like that?
Yeah, that's actually a really good question. So one of the studies specifically was looking at graduates from the University of California, San Francisco. So this is a highly competitive medical school where these, graduates have numerous opportunities, and they still saw that, Black residents, Hispanic residents who graduated from their programs tended to practice in areas that had higher concentrations of populations that look like them. So there is that desire there, even when, people are coming from institutions where they had multiple opportunities. So I think we are kind of working on the pipeline. Eventually, we'll get there. I don't think 77 years is quick enough. But I think, there is a desire from graduates from these populations to go and work in, more medically underserved.
Wonderful, thank you. And disparities, I think, probably extend much further into our education process. Do you know of any ways or groups to get even younger kids encouraged into medicine to think of that as a potential career?
Yeah, of course. I think the SPEP program through the AAMC, I think it's housed at 20 institutions. There is not one here. I'm not sure exactly where the closest one is to us for college students, but the Office of Diversity programs, when I was a medical student here, had multiple opportunities for, medical students to get involved in that type of recruitment. We went to high schools and did anatomy presentations. They have the Summer Scholars Program, which is a pretty intensive program for high school students where they're here, I think, on the span of multiple weeks, where they come in on Saturdays and they go to the anatomy lab and do dissections and have occupational therapy, physical therapy, medical students, all kind of interact with them. So those programs are definitely other things that we could get involved with, as residents to promote, to increase kind of our pipeline.
Wonderful. Thank you for those responses.
Yeah, Kevin's here. He's ready for you.
There. Hello. Thanks again for your talk as well, and for sharing the mic. A question I had for you, kind of pertains to bias as well. You mentioned in your K-clustering ICU example that this was essentially unbiased data. Is that true? Do you think that is the data large enough that we've taken bias out of the equation, or is there a high risk of having biased data that we, like you put in garbage, get garbage out? And if so, how do we avoid that bias when we're starting to use this data?
Important question, I think. The short answer is no, the data is not unbiased. The data was collected by us, biased individuals in a biased medical system, as Kai has just pointed out to us. And when we use the terms like unsupervised and unassisted machine learning things, we have to remember that the machine itself has not introduced any bias into this particular calculation, but we, in choosing the parameters, have our implicit bias introduced into the algorithm, what we as humans carry with us. And I think the punchline to this discussion is basically that we need to continue to remember the humanistic side of medicine. We need to remember to check ourselves very frequently, because ultimately what we pick goes into the algorithm is going to reflect what comes out. So.
All right, unless there's any further questions, I think I'll just say a big thank you to both of you for fantastic talks. Congratulations, both super informative and very well done. We're so proud of both of you and impressed with all the work you've done. So thank you so much for joining us, guys. We really appreciate it.
Thanks, John. See you guys.
All right, make sure to come back for us next week, everybody. We have 2 more amazing senior resident talks. They'll be the last of our senior resident talks next week. We're happy to have you come back, and please, if you want to catch up on any talks you missed, hit up that YouTube channel at the Department of Medicine website. Take care, everyone, and thank you.